IFIS is characterized by billowing of iris, progressive intraoperative meiosis, and prolapse of iris through corneal incisions during phacoemulsification. Though classically described with tamsulosin, it is associated with various other medications and clinical conditions including hypertension. This was a patient on tamsulosin and the pupil was just mid-dilated. Adrenaline was injected to dilate the pupil. Capsulorhexis was done under dispersive OVD. Care should be taken not to overinflate the anterior chamber, which can trigger iris prolapse. Side ports and clear corneal incision should have long intracorneal tunnel to reduce the incidence of iris prolapse. You can see the prolapse of iris during hydrodissection. Hydrodissection should be gentle with multiple small fluid waves because it is during hydrodissection that the cascade of IFIS starts. Phacoemulsification was carried out using low parameters, that is low bottle height, vacuum and aspiration flow rate. Here there was fluttering of iris, progressive meiosis and tendency for iris to prolapse through the side port where the dialer was placed. Now I had reduced the phacoparameters. The anterior chamber became stable with less turbulence, iris fluttering and tendency for iris prolapse. Though it takes slightly longer to complete the surgery while lowering the phacoparameters, it is very helpful in maintaining the anterior chamber stability and reducing the manifestations of IFIS. Emulsification of nuclear pieces was carried out in the supracapsular plane so that the fluid waves do not pass under the iris and lifts it up. Cortex aspiration was also done using low parameters. The capsular bag was filled with OVD and a single-piece foldable acrylic IOL was placed inside the bag. During all these maneuvers, the endothelium was protected using dispersive OVD. Pilocarpine can be injected intracammerally to conceive the pupil. The side ports were hydrated gently without causing any further iris prolapse. This was another patient on tamsulosin. There was anterior chamber turbulence and iris fluttering during surgery. Once the phacoparameters were reduced, the anterior chamber became stable throughout and I could complete the surgery safely. We can use pupil expansion devices in case of poor pupil dilatation. In this patient with severe IFIS, where Malyugin ring was used, the iris in between the scrolls was coming towards the phacoprobe. We can use iris hooks or Behex ring to provide adequate visualization. If planned and executed properly, in most cases, phaco can be carried out safely in these patients.